Alrighty, so welcome again to today's webinar about diagnostic tools and eosinophilic disorders. Also, happy National Eosinophil Awareness Week. My name's Jennifer Roeder, and I'm a communications consultant for APFED. I'll be moderating today's webinar. This is the first in a two-part webinar on emerging diagnostics. Today's webinar will focus on unsedated transnasal endoscopy for eosinophilic esophagitis, or EoE. We'll hold a second webinar in September that will be focused on esophageal strain test for EoE. For today's discussion, we have three panelists joining us: Dr. Diana Lerner from University of Wisconsin, Dr. Paul Menard-Katcher from the University of Colorado, and Dr. Eitan Rubinstein from Boston Children's Hospital. We're pleased to have such a wonderful panel of doctors for today's discussion. Before we dive into discussion, the doctors have prepared some overview information about diagnostic tools for eosinophilic disorders, particularly EoE. Then we'll spend the majority of today's webinar having a discussion about unsedated TNE. First, we'll hear from Dr. Rubinstein, who is a pediatric gastroenterologist at Boston Children's Hospital and an associate professor in pediatrics at Harvard Medical School. He will share information about the role endoscopy plays in diagnosis and management of EoE. We'll go ahead and let you share your screen.
Okay, let me see if I can get this to work. How's that?
Looks great, thank you.
All right, so thank you so much for putting this together and for allowing me to speak to you today. Like was mentioned, I will be giving a very brief overview on a little bit of eosinophilic esophagitis and mostly the role of endoscopy. It's not advancing. There we go. I have nothing to disclose that is relevant for this talk. Now, as most of you out there know, eosinophilic esophagitis is a chronic inflammatory condition. It involves inflammation of the esophagus, which if left untreated can lead to fibrosis or scarring and eventually narrowing. Luckily, we're at a point where we have a good number of therapies available. These range from dietary interventions to medications. The dietary interventions can be anywhere from single food eliminations to more extensive eliminations. Both of those are clinically applicable in different settings. From a medication standpoint, we have a few. Proton pump inhibitors have recently been identified as a therapy for eosinophilic esophagitis, as opposed to what we previously thought of them as a way to distinguish eosinophilic esophagitis from reflux. Topical steroids are probably the mainstay of medication therapy for EoE at this point. And then the newly, or maybe not so newly, approved FDA medication, dupilumab, which is really the only medication that's FDA approved at this point to manage eosinophilic esophagitis. Now, a little bit of background on the disease. A major issue with eosinophilic esophagitis is its symptoms tend to correlate poorly with disease activity. Even with our newer diagnostic or symptom scores, it still is the symptoms that we see with eosinophilic esophagitis tend to be non-specific. These include abdominal pain, heartburn, trouble swallowing, and while we definitely see these with EoE, they're also common in other conditions like gastroesophageal reflux disease, functional dyspepsia, and infections. The other thing that makes it tricky when we're trying to follow our patients symptomatically is that many of our patients develop coping mechanisms or coping skills to deal with their symptoms due to the chronicity of disease. Whether this is excessive chewing of their food or drinking fluids with their meals, we all know the patients who, for some reason, tends to be more teenage boys who present to our office and swear that they're completely asymptomatic, and then we see them a few days later in the emergency department with a food impaction. This has unfortunately led to the need for multiple endoscopies to diagnose and monitor the condition, especially to reassess the response to therapies, which were mentioned earlier. Now, is this a problem? Well, The FDA issued a communication in 2017 warning that general anesthesia may negatively affect brain development in children under 3 years. Now, additionally, and this was based on animal studies, they reported that sedation and general anesthetic drugs for more than 3 hours could lead to nerve cell death in developing brains, leading to behavioral and learning issues. Which brings us to where we are now, and the reason why I think we're having this webinar at this point, which is the fact that eosinophilic esophagitis is a chronic condition. It's inflammatory and requires often reassessment, whether that's to assess for symptoms or anytime we make any interventions from a therapeutic standpoint, and the potential risks of general anesthesia has led us to really work hard as a field in general to find less invasive modalities and diagnostic tools for all of this condition. And with that, I'll pass it back to Jen. I'll stop sharing my screen.
Wonderful. Thank you so much. Now I'm pleased to introduce Dr. Paul Menard-Katcher. He's an associate professor of medicine in the Division of Gastroenterology at the University of Colorado School of Medicine. He's also part of the consortium of eosinophilic gastrointestinal diseases researchers, known as SEGR, and serves on the medical advisory board of EvoEndo. Dr. Menard-Katcher is going to share information about emerging, less invasive diagnostic tools for EoE.
Thanks, everyone. Can you hear me okay?
Yes, thank you.
All right, perfect. So thank you to APFED for organizing this. Thanks to my co-speakers and to Jen for moderating. I think it's an important topic of conversation. As Dr. Rubinstein alluded to, we're frequently assessing esophageal pathology repeatedly in eosinophilic esophagitis. And as such, the burden of endoscopy has led to the desire for less invasive diagnostic tools, both in eosinophilic esophagitis and importantly in other upper GI tract diagnoses. And then I come from an adult gastroenterology perspective, and so I think there's a little difference in mindset that we can get into hopefully during the discussion. As Jen alluded to, I am on the medical advisory board for EvoEndo, which is a novel transnasal endoscope company. And these are kind of examples of what people have tried for less invasive esophageal sampling and monitoring. On the left, you have the EsoCheck device, which I'll get into. In the middle, the Cytosponge device. And then on the right, the esophageal string test, which, as Jen mentioned, will be the subject of a subsequent webinar. So these are the sampling methods that we have to discuss, and then Diana, and then this discussion will then later focus on unsedated transnasal endoscopy. So for less invasive sampling, one of the options that we have available is the esophageal string test. Essentially the details of the string test are presented on the left. There's a capsule, a weighted capsule with a string put inside the capsule. You hold on to the end of the string and then swallow the capsule, which then dissolves, and then the string traverses the length of the esophagus. The weighted ball at the end of the string allows it to get all the way into the stomach and even the small intestine if that assessment is desired. The string dwells in the esophagus for an hour, at which point it is removed. The esophageal portion of the string is cut and then placed in tubes, and then a laboratory runs an analysis to quantify, in this case, proteins that are associated with eosinophils. On the right, you have a picture of Jasmine, who's one of our research assistants, just proving that the esophageal string test is well tolerated. We've been involved in this research for quite some time, and multiple of our research assistants and myself have undergone this esophageal string test. So advantages of the string test and patients in whom to consider it is that it's been studied in a large number of both pediatric and adult eosinophilic esophagitis patients. And then results from the esophageal string test correlate fairly well with endoscopic findings and esophageal biopsies. And then furthermore, no specialized equipment is necessary to collect the string sample. It's just collected in clinic and then sent to a centralized laboratory for analysis. On the right, you can see that the size of the capsule approximates the size of a Tylenol capsule, so is usually readily swallowed. There are some drawbacks. In our studies, up to 14% of patients were unable to complete the test due to gagging. If you have a significant gag reflex, the string just dwelling across the oropharynx and in the throat can be problematic. And it is a longer test. It does require the string to dwell in the esophagus for an hour, so that can be a downside to some patients. That said, again, it is performed in an office setting and requires, again, no specialized equipment. And so this has been looked at in eosinophilic esophagitis and is currently being evaluated in other adult esophageal pathology as well. The next less invasive sampling method to discuss is the cytosponge. And if any of you with children, the analogy I use is that this is kind of like those capsules that have the dinosaur sponges inside that my kids loved back in the day. So it's essentially a small capsule, and within it is essentially a sponge, and the capsule is swallowed similarly with a string attached. The gelatin dissolves in the stomach, and then the sponge expands. After sponge expansion, the string is pulled up, and the brushes on the sponge sample the esophageal mucosa. On the right here, you have comparisons. On the left, you have the cytosponge samples, and then on the right, you have conventional endoscopic biopsies, and these have shown to correlate fairly well. This is my colleague, Dr. Wani, who both him and myself performed the cytosponge on each other to prove that it was tolerable prior to examining this in Barrett's esophagus. There is good correlation between eosinophil counts and cytosponge by cytosponge and then biopsies in same patients on same day. And cytosponge has received higher patient rating scores than endoscopy in research settings. It can be performed by a clinical nurse in 10 minutes, so thus obviates the need for endoscopy and all of the pre and post procedure assessment, and then is a shorter test than the esophageal string test. And then it also has a distinct advantage in that it can be processed by standard laboratories. The sponge is spun down, and then the pellet of tissue is then examined conventionally by our pathologists. Downsides might include that 7% are unable to swallow or have persistent gagging. That does not include the discomfort of the sponge coming up the esophagus and the throat, which is not the most pleasant feeling, but eminently tolerable. Importantly, the cytosponge has only been studied in adults. And furthermore, in studies in Barrett's esophagus, patients with difficulty swallowing or dysphagia were actually excluded. And while it has been used in patients with strictures in eosinophilic esophagitis, currently it is indicated for patients without dysphagia. So any patient with dysphagia, as many of our eosinophilic esophagitis patients have, it is off-label use. And then the pooled sensitivity is approximately 75%, meaning you do miss some patients who might have eosinophilic esophagitis, where the sponge might be negative and the biopsies might be positive. Interestingly, there is also a less than 100% sensitivity for esophageal biopsies compared to sponge test, meaning that some patients were found to have positive sponge biopsies but negative endoscopic biopsies, which is just an interesting aspect of the studies to date. So with that, we'we'll move on to the last minimally invasive sampling device. This is the EsoCheck. This is also placed transorally, unsedated, and can be done in the office. This is a product from Lucid Diagnostics. And essentially, in that bottom right picture, you have a deflated balloon that is placed into the esophagus, into the stomach, and then the balloon's inflated and then has ridges that then, when the balloon is pulled up into the esophagus, sample the esophagus. Advantages to the ESO check are that, again, it can be used in the office setting, is very quick, less than 10 minutes, and then can be sent to pathology. This has only been evaluated in Barrett's esophagus and has not yet been evaluated in eosinophilic esophagitis or in children. So with that, I'll stop sharing my screen and we'll move on and learn from Dr. Lerner.
Wonderful. Thank you so much. Our third panelist is Dr. Diana Lerner. She's an associate professor of pediatric gastroenterology at Children's Wisconsin, Medical College of Wisconsin in Milwaukee. She's also the director of endoscopy and co-director of the Aerodigestive program at North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, also known as NASPGHAN. Dr. Lerner will now present focused information about unsedated transnasal endoscopy, and then we'll proceed to the discussion portion of this webinar.
Thank you so much, Jennifer and ASFA, for putting this panel together. It's been a great experience. So I'm going to talk a little bit about unsedated endoscopy. And here are my disclosures. And so one of the questions we have to ask is, why offer unsedated endoscopy? And I think Dr. Rubinstein and Dr. Menard-Katcher have made a really good point that the high burden of endoscopy in individuals with esophageal disorders yields itself really to better methods to investigate esophageal disease. And unsedated endoscopy has definitely received a lot of traction, as I will show you in the past, but also much more recently. So the advantages of and limitations of this approach. Advantages is that it's a high patient satisfaction procedure. It's generally very well tolerated, with some reduced gagging, as we know may be caused by some other methods. There's reduced cardiovascular stress in patients who are high risk. No sedation is required, no monitoring, and potentially can be used in an outpatient setting. In the event of a COVID type event, it is less production of aerosol generation with this procedure rather than the intubation or anesthetized patients. And in the studies recently done, it shows that it's not inferior to biopsy sampling compared to the sedated endoscopy method. The limitations are really rare. It's not suitable for patients with significantly altered nasal anatomy, high risk of epistaxis, patients who have a poor tolerance for nasal pain or discomfort. And then again, some of these may not be possible due to inability to intubate the nasal cavity. So interestingly, unsedated transnasal endoscopy is really not new. The first reports of this being done were reported in American Journal of Gastroenterology in 1991 by a patient who was not able to be intubated orally. And it was described as a very feasible method for endoscopy. And then actually in my own home institution back in 1994, there was a study of using 20 adult volunteers comparing unsedated transnasal endoscopy with a bronchoscope that reported really high, well-tolerated procedure and high success rates. After that, we had a development of reusable smaller caliber endoscopes in the 5.5 to 5.9 range, which some people call pediatric endoscopes or nasal endoscopes. And after that, in parts of the world, such as France, this became a very successful modality. So you could see this study looked at 1,100 individuals with a 93.9% success rate. And they actually were able to complete the procedure in almost everyone who failed the nasal intubation by the oral route. And they reported that the risk of failure really was related to a few factors, being younger than age 35, female gender, and the larger endoscope. So their hypothesis really was that the diameter of the nasal passage and the size of the endoscope would predict the risk of failure. So when it comes to nasal intubation, size really matters. And as we look further, I mean, even in 2016, you can see in Japan, this is you could see the graph looking at both hospital and clinic-based and endoscopic procedures, and up to a third of outpatient procedures in all of these clinics. So the N here is number of clinics across the country are performed in the transnasal unsedated route. So this really took off in parts of the world where this becomes really one of the standard assessments. But what becomes one of the major limiting factors as to why maybe it didn't take off so well in the North American population, even though it was described in the 90s, was lack of formal standardized training programs. So this was one of those things that sounds great, but how do I learn to do this? We don't teach this in fellowships. And so this study was actually really interesting. They randomized people in Switzerland, novel endoscopists and skilled endoscopists, to doing a T&E completely unprepared. So these were people who had to research the nasal anatomy on their own, had never seen one done, didn't have any sort of training about how to do it. And they randomized them to do 139 patients. And what they actually found is people did really well, even on their very first attempt of doing this procedure without any training. 99.3% had successful nasal intubation, 96% of patients accepted a repeat procedure, and the only major difference was that the skilled person was able to complete the procedure in under 6 minutes, and the novice, it took 20 minutes or longer. But even with that, 81% of patients who have had an endoscopy, a sedated endoscopy in the past, would still prefer the unsedated endoscopy, even in this case of a novice endoscopist. So since then, and this is a recent review in gastrointestinal endoscopy in 2023, looking at all the tools now available to facilitate this kind of procedure with both reusable and disposable endoscopes. And the proposed indication list really grew. So you could see here, I mean, really the biggest one right now, at least in the pediatric arena, is eosinophilic esophagitis. But you could see that Barrett's esophagus, reflux and infectious esophagitis, follow-up of celiac or diagnosis of celiac disease, dysphagia, vomiting, and there's a whole list of new diagnostic modalities that are being proposed as possible indications. The relative contraindication, as we talked about, is patients with abnormal anatomy. And then patient selection. So in really expert centers, the suggestion has been that kids who can follow instructions and cooperate with the procedure anywhere age 5 or older should probably be able to do it. But otherwise, in a newer program, probably over age of 8. So since this has become, really driven through pediatrics, there have been really a number of key publications, and I'm sorry if I'm missing other studies. This was just to demonstrate how much research has gone into this recently and how popular it has become. So talking about us, we started this program in our center in 2022. And I can tell you that initiating this program can be challenging because you need a team approach here. Just a doctor coming and saying, I want to do transnasal procedures isn't really going to work. You need the administrative ambulatory director, you need a diagnostic nursing director, you need your physician team, your clinical specialist. We needed to involve our EMR specialists to build out specialty tools for ordering. Our industry partners were very helpful. We needed to involve our financial services team to come up with billing and coding, and then internet of service analysis to make sure that we can do the system to use Wi-Fi enabled phones to distract patients during the time of procedure. Then we made an equipment acquisition list. In training service sessions were done. And so we were unique in our program that we did not have an ongoing T&E program before we started. And nobody was doing transnasal endoscopy. So we trained entirely on adult volunteers and the 3D printed model. And then we developed our patient selection. So like I said, for our center, we use 10 years of older. In our case, particularly, we started with patients who've already had a sedated endoscopy in the past. Currently, we're only doing diagnosis of EoE, but we're hoping to expand that as our skill levels expand, and then normal anatomy. This is Dr. Vaidi, my partner. We created this custom order set in our system so that our partners can refer patients to us. And you could see here kind of presets you to what questions we wanted to know that would prompt us to understand if the patient referred was a good patient for this kind of procedure. And then we had a system built out where once the order is placed, the order goes to the MA for scheduling, who then notifies the T&E nurse lead to provide pre-procedure instructions and educations to the family. So it's really an automated system. Once the educations are sent to family, they get to ask questions. We can definitely call them, but generally they're pretty good with the nurse education. With the day of the procedure, they check in and get a vital sign. Then they meet with our child life and nursing team again, who provide further education in the virtual reality kit. We come into the non-procedure room, so clinic room, and get informed consent. Then we transfer the child and a parent, if they choose to participate, to the T&E room where the RN administers the lidocaine via the nasal atomizer. We do the T&E with the family in room if they choose to stay. And post-procedure, we move the child back to the exam room They get a cold drink or a popsicle while the physician completes the report in the room. And then we have a brief discussion with the family regarding the results and what we saw. Repeat vital signs, AVS is given by the RN, and the child goes home. So from start to finish, we're generally under an hour. So I wanted to take you, to show you briefly this presentation. This was a case in a video that was presented at DDW this year, just in general what this looks like. So at first, you're going to see Dr. Mami, this is administering nasal lidocaine via the atomizer. And then putting a little bit of it on the nasal Q-tip around the orifice of the nasal entry. They're ensuring that the distraction system is working. You can see he's adjusting the chair to ensure that the nose is at the chest level, and that he helps keep the scope stable. Here you see the passage of the scope on the bottom of the inferior turbinate. It can also go in the middle, but as he passes the turbinates, he's going to see the adenoid there. And then the upper esophageal sphincter is at the top of the screen, which is not usually how we're used to seeing it. The esophagus is now intubated. And generally the scope is pushed all the way down to the stomach. He's going to take some pictures. As you can see, the patient is awake, so the swallowing and motility of the esophagus requires a little bit of patience to really see that really good visualization. Now he's investigating the stomach and also the small bowel. So this is a full unsedated EGD. Keeping that shaft of the scope parallel. And then now Dr. Rami is taking some biopsies, which are possible to obtain from all the organs he's visualized. And as soon as he's done with biopsies, with the support of his staff, he just removes the scope from the nasal cavity. So you could see the patient does really fairly well. So I'm going to stop sharing screen and send it back to you.
Wonderful. Thank you so much. It was really interesting to get to see the video to further understand how it works. So what we're going to do now is spend about the next 20 minutes or so talking through a series of different questions to help our patients and caregivers who are joining us today learn more about these different options and really focus on the unsedated transnasal endoscopy. So first question, with emerging techniques like less invasive diagnostics for EoE, does it take a long time to integrate them into your practice? I know you just went through this, Dr. Lerner.
I mean, I would say yes. You really need to have buy-in of your hospital system. That makes all the difference. It cannot be driven by one person. And you know, we always want the best for our patients. We want the best and newest techniques and technologies available to aid in diagnosis and therapies. But unless you have that hospital or clinic partnership on your side who see and buy into your vision, it's going to be very challenging. But like I said, it's definitely possible, but it does take some time and patience.
Dr. Rubinstein, would you mind sharing about your experience?
Yeah, I think Dr. Lerner is right. It took me a very long time to finally launch our program in Boston. I was looking back at my journey, I guess, if you want to call it, from wanting to do it to actually starting. And I worked with Dr. Fuliander in Colorado, to just see what it was about. And that was in 2018, January of 2018, and my first case was July of 2021. Again, COVID kind of threw a monkey wrench into a lot of it, but it took a long time to go see what this was about, come back to the hospital, I worked with ENT for a little bit to just learn the technique of going through the nose, which ended up not being super helpful, but that's a different story. They were so great. And then borrowing a bronchoscope from our pulmonary colleagues, practicing on some nurses and very altruistic colleagues and volunteers who wanted this to happen. But yeah, from beginning to actually doing my first case took 3.5 years.
Dr. Menard-Katcher, feel free to weigh in, but I'd also like to get, as you comment now, if you can walk us through the process of doing an unsedated T&E. We heard the process from the clinician perspective from Dr. Lerner. We'd love to hear the process from the patient perspective.
Yeah, sure. The only thing I'd add to the previous comment was that these aren't just one physician practices anymore, and so there's so many stakeholders that there's just a lot of moving parts, and that's why I think partnerships with patient advocacy groups are critical, because if patients are asking for something, there's a much greater chance that something's going to happen. So that's why webinars like this, I think, are a great idea. Partnering like we do with Seeger with patient advocacy groups, I think that's all critical, because it's really tough for a single provider to say, hey, I want to do this, and then convince a bunch of different stakeholders. Time is at a premium. And so I think partnerships like this, getting patient advocacy groups and patient panels involved is important. Now, from a perspective of transnasal endoscopy, I think one of the big advantages that we've talked about is this potential to have it done in clinic or in different settings. And I think in stark comparison, if you look how a conventional upper endoscopy is done, you come in an hour before your procedure. You're evaluated by either most usually an anesthesiologist who assesses your candidacy for what anesthesia is appropriate. You get an intravenous line or an IV placed. In the adult setting, that's just done right away. Then you meet your endoscopist or gastroenterologist, and they explain the procedure. Then eventually you're brought back to the procedure room. You undergo the procedure, which can take anywhere from 5 to 25 minutes. Then you go back to the post-operative care location. We wait until you recover from anesthesia, and then explain the findings, get the report. You have to have someone in the adult world, you have to have someone drive you home who's potentially also missing work. So it's essentially a multiple hour long process for 2 people, and then an entire day for 1. You compare that to unsedated transnasal endoscopy, which can be done in the clinic, which is where I've performed it, where you come in alone for your clinic visit, you get your consultation, we determine if a transnasal endoscopy is appropriate. If it is, we bring you back to one of our procedure rooms, get it set up. Then eventually I come back there, perform the procedure, take the biopsies, send those to pathology, and then that's it. So in addition to the advantage of not needing someone else to drive, not needing sedation, there's also the potential for a significant shortening of the diagnostic process, right? If I see you in clinic on day 1, I can decide you need an endoscopy that day and do it, get the information within a couple days, the biopsy results. Whereas if I see you and need a sedated endoscopy, I'm ordering the endoscopy, you're dependent on the endoscopy schedule, and then the results down the line.
Would you guys recommend to a patient that's coming in that might be getting the procedure, is there anything they could do in advance to prepare for it? For the unsedated T&E specifically?
I think it's going to be a big difference, I think, between the adult and the children patient populations. I warn my patients that they might be a little uncomfortable, but they're just going to grit their teeth and bear it. I have not to date used the distraction techniques of my colleagues here, but we have a conversation. Often I'll have a screen behind me that the patient can watch also, and that's interesting to some or disconcerting to others. So, but yeah, to prepare for it, I just tell people it might be a little uncomfortable, but it's going to be quick. It's a couple minutes, and it's usually readily tolerable.
We encourage people to watch the available multimedia about what they're going to experience and what it's going to be like. I think the worst thing that can be is they come thinking that it's going to be like the sedated endoscopy. They won't feel anything. It's going to be totally fine. And then they're completely struck by the fact that this is still a medical test, and it's not a completely fun experience, but it's overall probably more pleasant than the entire half day of their life being gone in recovery from anesthetic, which we also know is not a fun experience. So people need to understand that there's going to be some pressure in their nasal cavity, that they will feel it, but it's tolerable because, you know, the anesthetic that we use works relatively really pretty well. And usually the other thing we tell kids is if they've never had anything sprayed in their nose, that could feel really weird. So we ask them to practice like nasal sprays for a little bit before, so that they're not shocked by the experience of having something that doesn't taste very good sprayed up their nose for the very first time. And then ensuring that the parents also, and the patient selection is right. In our case, you know, adults can make this decision for themselves, but the parent is making the decision for the child a lot of the time. So ensuring that that patient selection is proper.
I would agree. I think we're a little more touchy-feely in the pediatric world than the adult world. So yeah, I mean, I definitely, like Dr. Lerner was saying, I spend a lot of time talking to them beforehand about, this is an uncomfortable procedure. Do not expect it to not hurt, because I don't want them to be surprised and think that something is wrong because they have pain in their nose, or they feel, you know, I usually say it feels like a stuck burp in your chest, and that's normal. That doesn't mean that anything is wrong. That's what it's supposed to be. We talk about the benefits of the procedure versus, you know, the downsides, and the downsides are it is more uncomfortable than a general, you know, than going to sleep and waking up in another room. The benefits is you wake up and then you can go back to, you know, in this case, you don't wake up, you leave and you can go back to your activities. You can go to soccer practice that evening. So it's a trade-off, but I don't try to minimize the fact that it will be an uncomfortable 10 minutes, like going to the dentist. It's not fun, but it's 10 minutes and it's done. I've recently started asking my patients to start practicing some breathing techniques. One of the things that has made it more uncomfortable, I've noted, is some kids want to hold their breath while this is going on, and that can make it worse. So I tell them, you know, practice some breathing techniques, diaphragmatic breathing, or just go online and look at, you know, breathing techniques. If you're doing a good job with your breathing, it'll go faster, it'll be less painful, and you'll tolerate it a little bit better. But that's something new that I've started talking to my patients about.
Yeah.
I like that you coincidentally said that they don't have to go back to school.
So I used to say, this is great, you can go back to school, and found out that that was not a selling point for the procedure. So now I say you can go back to soccer practice.
Yes. We also have a child life specialist meet with every family. You know, not everybody has that service available, but they have been fantastic because they really know how to prepare somebody for what's about to happen. Their job is to take a person through a procedure that's in a way that they can handle it. They give them a stress ball to hold the whole time, and my nursing team and I always remind the patients to keep breathing their procedure, because they're trying so hard to do a good job that sometimes they forget to breathe and they can faint. So I'd say I think those skills are good.
Have any of the patients that you've performed the procedures on give you any analogies about like what it feels like to them?
I've mentioned that the stuck burp is what I've heard. Like you have a burp in there that you can't get out. That's what the chest feels like. The nose is, I've heard different things. I've heard that it hurts. I've heard that they don't feel it, you know, and everything in between.
Yeah, I think most people actually are surprised by how much better it goes than they anticipated. I feel like you know, we tend not to ask the kids right away how it went, because we know that's probably not the best time to inquire about it. But honestly, like a week later or so, people are like, yeah, I'd rather have this than go through the sedated endoscopy again. But yeah, not too much complaints. And we actually rate every single T&E that we do. We rate on a scale of comfort, like comfort 1 to 5. And the majority of my discomfort scales during the case are 1 or 2.
Okay. How many biopsies can be taken during an unsedated T&E? Dr. Menard-Katcher, why don't you take this one?
I mean, there's no limit that I can think of, and you know, it's just time-based. So, for example, for eosinophilic esophagitis, conventionally 6 to 8 biopsies is considered the ideal number for diagnostic accuracy. So that's usually what I strive to obtain. It's been well documented in research literature that there's not a significant increased risk in taking more biopsies, and so it's really just whatever you need to get. It's going to change the duration of the procedure. That's really it.
What does it feel like for a patient? Perhaps Dr. Lerner, you can answer this one. What does it feel like for a patient when the biopsy is physically being taken?
In my personal experience, I haven't actually had patients feel them. I was expecting them to, because sometimes under anesthesia, we see them move a little bit when you take the samples, but unsedated, I haven't really had anybody complain. And even I thought maybe more so with proximal, but I haven't had anybody say, oh, please stop, or that's not comfortable, or at least they don't share it.
I've asked my patients because I was also curious, and usually nobody has told me that it hurts, but I have had some patients that say they feel like a pull or a tug, especially in the proximal esophagus. But I haven't had anybody who's been very uncomfortable with the biopsies.
Dr. Menard-Katcher, how often can an unsedated T&E be performed, and how does that compare to traditional endoscopies?
Yeah, I saw the question in the chat. There was also something about the frequency with respect to food reintroduction. And so again, this is, it really depends on the clinical indication. There's not a reason someone couldn't undergo a transnasal endoscopy every day of the week. Not that they would want to or it would be needed. But from a strictly procedural standpoint, I can't think of a reason. Essentially I consider them, apart from some special scenarios, which we could probably discuss, like the need for dilation, I consider them essentially equivalent procedures, just done differently, with both pros and cons. And I think in our case, we all see the dramatic pros to this approach. And then the question was about the frequency with respect to dietary elimination. I think really it's the amount of time in eosinophilic esophagitis that you want exposure to the reintroduced allergen that's going to determine the interval with the procedure rather than the procedure itself. So the procedure itself doesn't determine that interval. It's the amount of time that you want to get exposure to the potential allergen that's going to drive the timing.
Something that may get paired with a traditional endoscopy is a dilation, or using a balloon to be able to stretch it. Is a procedure like that possible to be paired with an unsedated T&E? Dr. Lerner, would you be able to share?
I saw a case report that suggested it. I personally would not recommend it, because when I do dilations, I want the patient anesthetized for comfort reasons, and I also want an endotracheal intubation for safety of any sort of fluid or control of any sort of complications that we may encounter, even though the procedure is relatively safe overall and these happen rarely. But I'd want my OR environment or his procedural suite environment to be able to manage whatever needs to happen. And also I think those can be very uncomfortable if done properly. So I would not subject somebody to that unsedated.
Yeah, I agree. I think it's mainly from a comfort standpoint. This is, they can be uncomfortable procedures. You're trying to induce some trauma to the esophagus. That's the goal of the procedure. And I think it would be a lot to ask. I know Diana mentioned that there were case reports of dilation being performed with unsedated transnasal endoscopy. And then the other complication is frequently the tools that we use, they can't be used with a super slim endoscope. So you can't put the balloon through the scope. So you're forced to use a conventional endoscope.
Dr. Lerner, when you were sharing information earlier, you showed different sizes of different endoscopies. The unsedated T&Es that are being used today, how big are they? Is there anything you could compare it to?
Yeah, so they really range in size. All the available tools out there range in size. I think the smallest is a 3.3 millimeter gastroscope, and then it goes up to all the way to 6 to 6.5. And like I said, the earlier procedures and some procedures around the country now are using bronchoscopes, and then some of the either transnasal endoscopes, or some people call them pediatric endoscopes. So it really depends what the center has or what they're using, but we use the 3.3 millimeter endoscope, which is about the size of like a pencil eraser, just for kind of comparison's sake. And then, smaller than a person's finger. And so that's what we tell the kids, if you can pick your nose, this is smaller, and should feel more comfortable than that. And the kids kind of understand that analogy better. But they are really, really small. And so I think knowing that it's probably like a moderate size NG tube, which some patients will have experienced in their life.
Okay. We have an individual interested in more granular data on the percentage of patients that were not able to tolerate these methods. Can you recommend where they could go to take a look at that? For example, they're interested in people both less than and greater than 2 years old, like how that varies.
So
Go ahead.
Oh, I was going to say, I don't know of any data with less than 2 years old with any of these technologies. I can tell you that from the cytosponge perspective, that it hasn't been studied in kids, and so the failure rate was about that kind of in that 7% range for adults. And for the string test, it was a little higher in that 10 to 14, but that did include children. And then I would assume that in the discussion about transnasal endoscopy on the future webinar, they might be able to get into that. And then the granular data might be in the supplemental information to the publication on transnasal endoscopy that was in, I believe, the American Journal of Gastroenterology.
Okay.
I was just going to mention that there was a study, I think, put out by the Colorado group where they did 300. They looked at 300 procedures, transnasal endoscopies, and it was only 6 that weren't able to tolerate it. So really high success rate. I'm not at the 300 or 1,000 or whatever they're at. I'm only at 25, and 24 have been successful. One of them wasn't. So whatever that percentile is, I don't want to do math in front of everybody on a webinar, but 24 out of 25 were successful.
Yeah, I think across the literature in general and more of the analyses, it's over 95% success rate. So, but again, no data under age of 2, because you have to cooperate with the procedure. This can't be done against your will. So I'd say that's why I mentioned, 8 years old and older, maybe in a very cooperative child and a very experienced transnasal endoscopist, 5 and older.
Gotcha. As the 3 of you look at the histologic eosinophil counts for the unsedated T&E and the traditional EGD, are you seeing differences?
I actually went back recently and looked at biopsy size of my patients who've had now both sedated and unsedated endoscopies and what the pathologists are able to read out. And I did not find a difference. I mean, most of the sample sizes are pretty equivalent.
Yeah, there's ample data on this in both the eosinophilic esophagitis, Barrett's esophagus, that biopsies from the transnasal endoscopy biopsy forceps and the conventional forceps correlate really well.
Yeah, I started off using a bronchoscope when I started my program, and the channel was too small for our standard biopsy forceps. I was using a SpyBite through it, and I was a little worried about the size of my biopsies, but I talked to pathologists and they were very comfortable saying that they could interpret it with even the smaller size pieces. Now with the disposable scope, I can use a standard biopsy forceps, so it's not an issue at all. It's basically the same forceps that I would use on a smaller kit anyways.
Okay. We've got some questions about the virtual reality. We saw the goggles on in that video, and I know not all of you use it. So Dr. Lerner, this may be more pointed towards you, but they're curious, like, does it help someone who's fearful? Like, how exactly does that work? We actually, APFED did a podcast with a young girl who went through it, and it was interesting hearing her talk about the virtual reality goggles and how much she enjoyed it. I'm curious, like, is it helpful for someone who's fearful, a child?
Yes, I think it is helpful. it's called a dissociation system. And so in other aspects of medicine, this has been studied to show that your heart rate goes down, your blood pressure goes down, you generally feel more calm because you're in a different place in your mind. You're not concentrating on the procedure itself at hand. And so I do feel like some kids actually prefer not to have it. And they do fine. They either just want to close their eyes or they've had it before and they feel fine for that. But for that very first time, when you don't really know what to expect and you're a little bit fearful, it takes your mind off a thing because you're thinking, I'm going to watch my favorite sports team play. Unfortunately, right now we're showing them something that played 5 years ago, but they're still pretty excited to see, even if it's an old, Manchester United tournament or something, but they're still pretty excited about it. Or we're watching, they're watching their favorite cartoon for that 10-minute period. So it's something. And the other thing that we do when they're watching the show is it gives us something to talk to them about because we can hear the show live in the room. So like, hey, what's the score? How's it going? Tell us a little bit about what's going on. So really we're communicating the whole time. We're part of that experience. And I do find that it is helpful.
You guys have mentioned that severe gagging response can be a negative indicator to performing the unsedated T&E. How do you kind of determine that? We've got an individual joining us that said they've got a teen with an NG tube phobia and a severe gagging response. Like, is there a way to make an unsedated T&E successful, or is that just saying like no go? How would you approach that? Either Dr. Rubinstein or Dr. Lerner, maybe?
To me, that sounds like maybe not the best candidate in the world. I think that this is a great tool and great technology, and it has some benefits, but I don't think it's for everybody. I truly do not think that we should be doing this on every single kid. If kids don't do well with medical procedures in general, and what I usually use is the blood draw. Like, how do they do with the blood draw? If somebody gets very anxious with blood draws, maybe it's not the right thing for them. If somebody has this very severe phobia of, the COVID test, the swabs in the nose, or NG tubes, or have had negative experiences, then it's probably not the best thing for them at this point. Yes, we could try, but in those cases, I think that a standard endoscopy is probably a better idea. And if they want it, then that's one thing. I would just be very cautious about the difference between a parent wanting the procedure done and the kid wanting the procedure done. If it's parent driven, that's probably not great. If the kid is motivated enough, even if they have those things, then I think that's worth a shot.
And I think that's a really great point because in EoE in general, right, we talk about shared decision making for literally everything we do. This is a diagnosis where the person has to buy in to the therapy methods that they're choosing. And a lot of it depends on the child kind of buying into, doing the things that we're asking of them. And this is no different. The patient has to buy in to this procedure. And if they don't want it, they're not the right candidate.
Thank you. You all talked earlier about the unsedated T&E being able to go down into the stomach, and it brought up a question for one of our listeners today. So can the unsedated T&E be used for lower egids, such as eosinophilic gastritis or duodenitis?
Yes. No, I would say that that in the appropriate setting, yes, you have to. It depends on the length of your scope. So you want a scope that can make it down into the stomach and small intestine. But you can take biopsies similarly. It's going to be a little more dependent. I don't know what you guys think. A little more dependent on endoscopist experience, especially if we're talking small bowel intubation, because it's very different than conventional endoscopy. But I think these are some of the important emerging indications for unsedated transnasal endoscopy. For example, in Asia, where they have high incidence of gastric cancer, almost all gastric cancer screening is done transnasally, where they're looking at the stomach in an unsedated fashion.
So this is all leading to the question of where is this available? When will it be widely available? Do any of the three of you have any comments for how people could find if their practitioners are using it, or how to find one that is offering it?
Well, I don't mean to give more work to you, Jen, but I think this is where you partner with patient advocacy groups, and if
Yeah.
you guys have a repository of practitioners who perform transnasal endoscopy, and then importantly with respect to uptake, then I think it really does need to come from patient populations to say, like, I don't want to miss a day of work. I don't want to have my friend miss a day of work. Right now it's convention, but convention can be changed, hopefully.
So APFED has a specialist finder on its website. So if you go to apfed.org/specialist, it's a tool that you can use to find specialists that treat a variety of eosinophilic disorders. And one thing we're currently working on is developing a new badge to add to the different listings to let people know when some of these new emerging technologies are being used by different practitioners. So stay tuned for that to be added to APFED Specialist Finder. We're hoping to add that to that later this year.
But I think also, even if your team doesn't perform it yet, asking for it will drive the system to develop these tools around your area, because that's really patients drive a lot of the change by attending webinars such as this and learning about something new and bringing it home. And then your motivated physician team has a leg to stand on to say, really, this is happening around the country. We've been hearing of it from patients. Can you help us facilitate this and offer it in our institution?
Yeah. Well, Dr. Menard-Katcher, you gave us a very nice overview of research of different types of work that's being done in this area of other types of tests. Do you see anything that's coming that we haven't talked about yet today?
Yeah, I mean, just briefly, and I know this is being recorded, but please don't quote this because it's off the top of my head. There's other areas that are expanding, right? There's the GRAIL project where they're looking for blood markers for cancers. That technology will naturally, whisper down the lane, ideally to inflammatory conditions like eosinophilic esophagitis. Looking for blood-based biomarkers. There are groups looking at exhaled breath products like volatile organic compounds in the exhaled breath to do almost breath tests for conditions. So I think as we move forward, this will all of these diagnostics will be changing. There's different prediction models where looking at different clinical factors, maybe pre-procedure, can determine likelihood of different conditions. So I think it's all expanding and out there.
Each of you have anything else you'd like to add to today's discussion about unsedated T&E? Dr. Rubinstein, we can start with you.
No, I mean, I think it's a great technology. Like I said earlier, I don't think it's for everybody, but in a properly selected group of kids, I only do pediatrics, but I think it has some great benefits. And right now, Dr. Menard-Katcher, you said that you do it in clinic. I'm only doing it in our procedure unit, but eventually I see this moving to the clinic where it'll be a lot easier to you see a patient, you want to assess them for EoE or other causes of dysphagia, and you could just take a look, and it turns what would be 2 days between the clinic visit and an endoscopy visit into one 1 hour and a half visit, and then you can start your therapy. So yeah, I think it's great technology, not for everybody, but I think the more people who are doing this, the better for our community.
Yeah, and I want to say that some of our patients who come from far away, we are combining their clinic visit with the procedure at the same time, which saves them a large amount of time because they're driving from sometimes 3.5 to 4 hours away to come see us. And then also the cost factor. I think this may be significantly cheaper for patients who struggle with, high deductibles every year. We remove the anesthesia charge. In our facility, we do it in the clinic. So we remove the operating room time, recovery time, which depending on a person's individual plan may actually save a lot of money.
Dr. Menard-Katcher, do you have anything else you'd like to share?
No, I think those are all really, really good points. I think, my hope is that, one of the big drivers for unsedated TNE has been those concerns about sedation and anesthesia in children. There's been less of that uptake in the adult population, but my hope is that, with parents who see their kids undergo unsedated transnasal endoscopy, that might precipitate them to ask about it for their colleagues or for their friends or for their loved ones. And then ideally, kids who get used to TNE become adults who, who want TNE. And that's, ideally that's the situation for me going forward. And then emphasizing the partnership with patients. Diana just mentioned it. If patients request things, that's what drives health systems. It's unfortunately not me asking for something.
Well, thank you to all three of you for such a wonderful discussion about unsedated TNE and EoE today. We really appreciate your time. Thank you also to our education partners for their support of this webinar series, including AstraZeneca, Bristol Myers Squibb, GSK, Sanofi, and Regeneron. If you would like to continue learning more about eosinophilic disorders, we encourage you to check out our annual patient education conference, EOS Connection 2023. This year, it will be in Denver, Colorado, June 30th, to July 1st, with some pre-conference activities on June 29th. There is also an option to join us virtually, but we hope you'll join us in person. In addition to that, we're also planning a special pre-conference webinar about EoE and inflammation. So stay tuned for registration details that'll launch next week. This week, as we mentioned at the beginning, is National Eosinophil Awareness Week. And just yesterday, for World Eosinophilic Diseases Day, we released a new podcast episode called A Global Look at Eosinophilic Disorders, talking about unmet needs with Dr. Florence Rufos. We hope you'll check it out. We've got a number of great episodes on different topics, and this one was very timely this week. And so our co-hosts, Ryan and Holly, really had a great conversation with Dr. Rufos. You can find the episode at apfed.org/podcast, as well as on Apple Podcasts, Spotify, Audible, and more. Finally, if you'd like to join in the conversation with other patients and caregivers, please check out our online community at apfed.org/connections. So thank you again to everyone for joining us today. If you have any questions that didn't get answered today, please email mail@apfed.org. And please help us continue to educate for National Eosinophil Awareness Week. I hope everyone has a great afternoon.